consumer purchase data and chronic disease and also other diseases. And the main questions that I'm going to address today is what is consumer data and how is consumer data used today? How can we use consumer data for research? What are the main challenges? Can we use consumer data to improve our health? And hopefully we can also talk a little bit about what to buy and not to buy to stay healthy. So what is consumer data? We all know what we do when we enter a shop. We get a receipt. It can be a paper receipt or digital receipt. And we have all the products on the shelves from that supermarket or shop that we enter to choose between. And that means that each receipt actually often resembles a 10,000 plus item questionnaire, as you have all these products to choose between. These receipts are collected by loyalty program, digital receipt solutions, and can be linked through transaction data. So just a quick census. Raise your hand if you're a member of a loyalty program, a customer club, receive digital receipts or personalized offers. There's a lot of people doing that. That's very nice. So this is also what we find if we ask people. So we share our data with many commercial entities. 90% of the population search for goods on the internet. 80% are members of loyalty programs. And this gives us some nice benefits. We have these discounts that we get. That is very nice for us. But it can also give some challenges. For instance, it can reduce the price transparency and also perhaps create an echo chamber effect. So if you buy healthy products, you'll get healthy offers. And if you buy unhealthy products, you'll get unhealthy offers. Today, I'm going to give you 3 examples of consumer data research. One actually just uses what is on the receipt. That is the direct use of the item name on the receipt. That could be strawberry yogurt. One product, one disease. I'm also going to talk to you about having classified the products a little bit, so you could combine different kind of groupings into, for instance, grouping salads and touche into greens, and then relating that to a disease or several diseases. So one product group, one or more diseases. And then finally, you can actually take one product and you can look into the ingredient list of that product, and you can look at the actual ingredients and then relate the product ingredients to your health. That's the last example. So starting with one product, one disease. At Statens Serum Insitut, we deal with foodborne outbreaks. This is a major health challenge also in the European Union. We have 23 million people falling ill each year and 4,700 deaths according to the WHO. And even with great effort, we are able to identify less than 40% of what actually caused the outbreaks. So could consumer data improve our success rate in this area? So we did try to look at it using a large and anonymized data set where we simulated multiple outbreaks from many different product sources. And what we found was that we only needed 5 cases in most outbreaks to be able to solve the outbreak using a simple logistic regression approach. And we can also see, and that's what you can see on the graph on the right-hand side, that as we looked at the individual products rather than looking at the product groups, we were able to solve more outbreaks. And the product groups actually relates to what you would typically get from questionnaire data. So as I mentioned, at Statens Serum Insitut, we do these foodborne outbreaks. Right now, we actually have a large salmonella outbreak with 60 cases. And the initial trawling questionnaires identified ground meat as a possible source of this. But we were not able to find out which product it actually was. So we collected consumer data. And after having collected data from 10 participants or 10 patients in this case, we found that the source was a specific brand of ground meat, and were able to, together with the Danish Food Safety Authority, issue a recall. We also do research, and that is what the remainder of my talk will focus a lot on, and that is done using this GDPR-compliant solution that Roxana mentioned, where we collect consumer data with the participants' consent to collect those data on an individual level with outcomes from the health registries. What we would like to do at SSI is also to be able to use consumer data to collect that with all suspected foodborne cases to have a continuous case control running using these data. I'll just briefly remain on this subject and talk to you about recalls. I don't know if you check your national homepages for product recalls, but they're actually quite interesting. So these are recent Danish recalls within the last couple of weeks. How about a cookie with metal shards, or perhaps flaxseed with prussic acid, or salmonella-infused bacon? These are all recent recalls, and I hadn't heard about them because they don't go into the general media unless it's big outbreaks. So maybe we could have a personalized warning instead, so that we got a notification on our phone if we had bought a dangerous product that we did not want to consume. Now, moving on to this subject about product groups and chronic disease. So we decided to try to look at the association between chronic disease and product groups such as tobacco and food purchases. And our hypothesis was that we would be able to reconfirm associations such as tobacco, smoking, and chronic disease found in previous studies. We used the SMEAP cohort with household consumer data profiles linked to registered data. I'll come back to that. And then we used a product pipeline developed as part of the HEAP product to classify products purchased into product groups. So once again, I'll just stay a little bit with the product matching. It is not a trivial process. So this is from our 2023 publication on this. And you can see here we start out with something like 223,000 products, and then we match it to this product data source that is called GS1. It's a global standardization organization for product data, and we can see how we generally manages to enrich the data more and more until we get to this step, which is a multiple regular expression step, and we ended up having roughly an enrichment process where we were able to classify the 88.5% of the products. We also tried to look at how we actually managed to classify the products, and we found that around 90% of products were actually classified as we expected, so that skim milk became skim milk, and a little bit more were classified with skim milk being just some kind of milk, not the right milk. We should also mention that we now have access to a lot more specific product data, namely from GS1, and that's more than 300,000 products. And we have great expectations that we will be able to do more with these kind of data. So now, continuing our look at this, this is actually a table 1 of the SMEAP cohort. So as you can see here, we have consumer data from 13,500 households. They cover 32,000 persons in total, and a total of 70,000 person years. If you look at the top line up here, you can see that they are classified according to whether being healthy in a register sense or having any of a number of chronic diseases according to ICD-10 codes and medication codes. And this is done based on a previous medication by another Danish research group. It should also be mentioned that the healthy population also includes some patients with psychiatric diseases and allergies, and that has to do with what we expect being the causal reason for disease of this concept. We also have this nice group of people that is called the incidence group. That's people changing status from having no disease to any disease during the time frame of the study. Also, I should mention that this is preliminary data, so please don't copy or cite. The average monthly budget is quite balanced, as you can see here, and this is the same with the household income and the observation time and the general coverage of the products. But if you look at age, sex, household size, and highest educational level in the household, you see marked differences between the groups. This is some of the very preliminary results. This shows the odds ratios of having any disease by the mean number of product purchases per month. It's a multivariate logistic regression, and we adjusted for some of the variables that you saw before. You can see here that cereals seems to be a good thing, and we also see that smoking seems to be a bad thing among butter, oil, and dressings, and confectionered chocolate, ice cream, and sugar. This is preliminary data, so it's not complete, but it seems reasonable based on previous studies, even though more work is definitely to be done. I have high expectations, especially for time to event analysis, looking at incident disease. But perhaps for now, it's safe to say don't buy tobacco products, too much candy. We also looked at this from another way. Now, the previous slide, we looked at the number of purchases over time. And this is another study by one of our collaboration partners that we also participated in. And here we looked at the monetary use of spending habits. So spending really tells you about the priorities that people make in the shops. So this was the spending habits of households with diabetes and without diabetes. And what we found was that first of all, regardless of being a diabetic household or not, the largest monetary percentages were spent on sweets. And we could also see that households with diabetes had a higher monetary percentage on classic unhealthy foods and a lower monetary percentage on several healthy foods such as vegetables. This comes with a number of strengths and limitations. Of course, there's selection bias, which is obvious if you need to have this kind of retailer card, and you also need this kind of, and you need to accept to participate in the study to even be part of this. And this is a select group as it is at the moment. We also have challenges with retailer coverage. We do not cover all retailers, though we did cover 3 of the 5 largest retailers in Denmark and 35 retailers in total. We have limited observations time. There are challenges regarding the number of people in the households and the number of purchase profiles that we get. We haven't complete, though we have nice databases and algorithms covering products, we have challenges, especially regarding doing analysis on weight volume. That was very nice to continue with. The data are highly correlated. And when we look at registers, absence of disease does not mean that you are healthy. And finally, of course, looking at prevalent disease, we have the risk of a reverse causation. I think some of these limitations can be addressed with our current research effort. And we still have the challenges I mentioned before with assessment over prolonged time frames, with low time consumption and low cost for participants. We have no social desirability bias. We have a potentially very fast translation of results. And we have this opportunity to do broad assessment of multiple hard to assess exposures. And this slide just actually illustrates this. This is about what if we could look at product ingredients. This is also something that we're currently doing and hoping to finalize during 2024. This is a word cloud of all the different chemical exposures that the smaller Danish cohort were exposed to. We found almost 2,000 different cosmetic ingredients identified, and we found a very broad variation in the exposure from each individual, with 19 products with at least one, on average, each individual had 19 products with at least one problematic ingredient, spanning from 0 to 450. So where do we go from here? This is kind of an illustration of the road to improvement, what we can do. So on the y-axis, you have the amount of information data that can be extracted using this approach. And on the x-axis, you have person years of consumer data linked to health outcomes. First of all, you can look at one product, one purchase. That's actually possible with a raw consumer data sample with a limited observation time. This is useful for outbreaks. But you can also increase the observation time, increase the number of participants and households coverage, and also start doing some matching and categorization of the products. And that allows us to do studies such as the one I just showed you some preliminary results about. You can also improve our product analysis, matching to make sure that we have more ways to analyze the data. And finally, of course, we can increase the number of retailers to reach something that could be called a complete consumer exposome sample. If we get towards that level, we'll have the power and courage to do very some studies that are very hard to do with the current research frameworks about purchases, ingredients, etc. So moving from simple association between purchase of tobacco, candy, and health to large-scale epidemiological studies of chronic diseases, everyday chemicals, food-drug interactions, over-the-counter drugs, and more. And if we combine this with other omics data, such as the excellent presentations given earlier today, we can probably gain some very important insights into complex disease activation and flare-ups, including inflammatory bowel diseases, cancer, and more. Now, being able to identify persons at risk is not the only way to, is important, but more important is to be able to actually prevent diseases. And what I really like about this approach is that it's very close to what people do in their everyday work. Michelle Morris Group in the UK have done some studies where they used vouchers to incentivize people from low-income households to buy more vegetables, and that seemed to work. And there are other studies that have done similar things. So I think we could really power changes in behavior using these kind of data. I'm a medical doctor myself, and in my previous work as a clinician, a common question from patients, what can I do for myself to change this situation that I'm in? And in many diseases, we don't have an answer, but in other diseases, the answer is, or conditions, the answer is more clear. So this is a thought out example. This could be a lady called Mona. She lives alone. She's overweight, and she's on the verge of diabetes, despite a recent weight loss on an expensive GLP-1 analog. Mona's doctor recommends a new app that provides lifestyle advice based on her health status and consumer data. And using this app, Mona reduces her candy and sugar-sweetened soda consumption, normalizes her blood sugar, and maintains her weight loss. She switches to digital control using the app. The reason why I give this example is because we have, with this way to do things, for a little group of patients, probably a possibility to move people from being on some kind of medication to moving out of the medication and changing to digital control. And I think this is crucial because of the age burden that we face in the years to come. So what I'm proposing is a framework for consumer purchase data epidemiology and precision prevention, where we collect consent to collect consumer data. We link consumer data anonymously using a new approach. We classify the products matched according to weight, ingredient lists, shelf life, etc. We collect health information on the same cohort. Researchers analyze the data, and then citizens can consent to receive targeted, relevant advice. It is, of course, important that this consent is very thought of. It should be completely voluntary, and it is also an option perhaps to include even differentiated consents to allow people to decide to some extent how data are used. We could also include some filters that would allow people to filter out things people don't like to share with researchers. On the other hand, users and citizens are very different, so it could also be possible to decide how you would like to receive information or advice in some kind of, for instance, traffic-like module. So my take-home messages today is with consumer data from large cohorts covering multiple retailers. We can increase knowledge on disease transmission, activation and progression, improve research and structural prevention, and provide precision prevention through simple prioritized lifestyle advice adapted to the individual citizen's household wishes, health, and treatment. And to enter the question again, what to buy or not to buy to stay healthy? Don't buy tobacco products, too much candy, or products that have been recalled. Thank you very much to Thorp Grønberg-Jungberg, who's present here today, and the team at SSI. I also like to thank Katrine Kold Sørensen and Christian Tobias Torp Pedersen, who's not present today from the capital region of Denmark, the HEAP consortium and Joachim Dillner, and of course EU for providing funding for doing this kind of research. Thank you.